The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. My name is Kaylin Henderson, and I will be your facilitator today. I think we're going to give it about another minute to allow a couple more people to join, and then we should be able to start with today's presentation. All right, it doesn't seem like we're picking up too many more people at this time, so I'm going to go ahead and start. Good afternoon, and welcome to today's presentation on patient access and how does it affect my practice. My name is Kaylin Henderson, and I will be your facilitator today. At this time, all attendee lines are muted for this session to minimize background noise and distractions. And we encourage your questions and input throughout this presentation, so please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation will include polling questions in addition to a short survey at the end, and I ask everyone to participate as we value your interaction. Please allow me now to introduce today's speaker, Dr. Edward R. Sobel. Edward R. Sobel, DO, is a retired senior partner, managing director, and was a family physician at Family Practice Associates of Wilmington, Delaware. He is currently the medical director of the Healthcare Quality Improvement Program for Quality Insights of Delaware, the State Quality Improvement Organization, as well as for the Delaware Regional Extension Center. His areas of expertise include clinical quality improvement, evidence-based medicine, practice management, and electronic medical record system implementation. Dr. Sobel is a senior attending staff member and executive committee member of the Department of Family and Community Medicine, Christiana Care Health System, Wilmington, Delaware. He is board certified in family practice, having earned his medical degree from the University of Sciences College of Osteopathic Medicine in Kansas, Missouri in 1973, and completed an internship at Parkview Hospital in Philadelphia, Pennsylvania. His awards include the 2001 Family Physician of the Year by the Delaware Academy of Family Physicians and the 1995 Preceptor of the Year for Christiana Care Systems. He was a finalist for the 2010 HIMSS Nicholas E. Davies Award of Excellence for Recognized Excellence in Implementation and Value from Health Information Technology, specifically EHRs. He received the 2011 Daniel A. Alvarez MD Service Award from the Medical Society of Delaware for helping to implement over 1,000 physicians on electronic medical records. And in 2012, he was certified as a clinician, practitioner, consultant, HIT professional by the Office of the National Coordinator for Health Information. Dr. Sobel, I would now like to welcome you to begin today's presentation. Let me go ahead and give you access. There you go.
Okay. Let's try to make this disappear here. Let's put it down to the bottom here. We'll be okay. All right. Good afternoon, everybody. Thank you for joining us today. I'm going to talk about access to care and improvement for better patient care. And I was actually thinking about this last night and said, this is just all directed to patient care, and sometimes clinicians begin to say, well, what's in it for me? And I really thought about it. It's actually an improvement for better clinician care, for clinicians to benefit from something, because too often we get asked to do things that just seem to add on to our day, more clicks, as clinicians will commonly say. And so I really wanted to try to balance it and show you that there's actually two parts to this, but I thought at the early hours of this morning was not a good time to start making changes in my presentation. And Caitlin, it is not dropping my presentation. I don't know why.
Let's see. I can't click. You're in PowerPoint, Dr. Sobel?
Yes, ma'am.
And it won't let you change slides.
No, it's not.
You try going over to the bottom left-hand corner of the screen, and there should be some sort of error that shows up. Does that work?
Let's see.
No, not there.
Nope, okay.
If not, can you try your keyboard?
Here, oh, wait. Okay, wait, let me see. Got it. Okay, we're good.
There you go.
There we go. So.
Sorry, guys, for that technical.
Yeah, well, now I got to make this bar at the bottom disappear because it's getting in the way of doing whatever I need to do. So I'm not sure where I can squeeze this bar to make it go away. Let's try this. Better. Okay. Okay, there we go. I think we're good, but let me see if I can move that one little bar over to the side and get it out of the way, and we should be good. And we're okay. Now we're good. Okay, so here's our learning objectives for today. Sorry about that. We're going to talk about what is access to care from a patient perspective. We're also going to talk about it, as I said, from a physician perspective. We're going to recognize some key aspects of effective strategies and discuss the value associated with each subcategory of continuity of care. So we're up to our first polling question. So Kaylin, if you want to post that question for everybody.
The first polling question is describe your position within the practice. And you can select either physician clinician, office manager, nurse, receptionist, or other. I'm going to give it a couple more seconds for everyone to go ahead and enter their we're up to 83% voted at this point. Let's see if we can get up to 90 or 100. Almost there, guys. Couple more. All right, I'm going to go ahead and close this poll. And I can go ahead and share with you guys those results. Here you go, Dr. Sybil.
I'm not seeing it, so for some reason it's not showing up on my end.
Okay. Well, what it does show is that we have about 4% clinicians and physicians joining us today, about 40% office managers, 12% nurses, 8% receptionists, and 36% other.
Okay, that works. Okay, so let's move on. Here we go. Okay, so easy access, that's what we're going to call it. And you've probably heard it called open access in the past. When we developed this at our office, which as you can see by this slide, I actually took from a PowerPoint presentation that we did almost now exactly 12 years ago. And when I was preparing this lecture, I found this PowerPoint presentation amongst my files of things that geez, why didn't I throw this out 10 years ago? And here it is. So anyhow, we called our access program Easy Access. Commonly, you may hear of it as open access. We didn't think that open access was really understandable by our patients. I changed the name to Easy Access with the idea that we would tell our patients that it was easy for them to access care in our office. So what is the goal as a clinician? Okay, so we first need to define a clinician. A clinician provides both the first contact for the person with an undiagnosed health concern, as well as, importantly, continuing care for a variety of medical conditions. And while this may sound like the definition for a primary care physician, it really applies to any type of specialty. If you're a surgeon, you're going to be taking care of the patient from the beginning when the condition may be undiagnosed until post-surgery and the patient is discharged from your practice. But there's obviously a continuing care, and that's the important part. Continuity, we can actually define as having a continuity of record. What do we understand about the patient? What's our plan in continuity, and a continuity of relationship all develops with the patient. And again, that continuity will vary based on specialty. As a primary care physician, as a family physician, our practice has been taking care of patients continuously since 1941. Now, I'm not that old, but over generations, we've been taking care of generations in our practice, so real continuity. What's access to care? Okay, what do we mean by access to care? Well, the IOM defined that approximately 25 years ago as the timely use of personal health services to achieve the best health outcomes. So there's the ideal definition of access. But what does that really mean if we kind of grind down on it a little bit? We need to have three things involved. One, the patient needs to be able to gain entry into the healthcare system. And typically we think about that as getting insurance or having some way of getting into the healthcare system. Then that drops down to having access to sites of care. So where is the patient going to go? If you have an insurance card but there's no place for you to go, you don't have access to care. But assuming you do get access to care, then we want to develop a relationship with practitioners who meet the patient's needs individually, with whom the patients can develop a relationship based on mutual communication and trust. And that's really important. And I think patients will tell you that pretty consistently. So what are the impediments to good care? And these four are there. Now, I don't want to denigrate the emergency department or the drugstore, the urgent care center. They have their time and their place. But really, if we're taking care of patients, we want the continuity. We're not looking for the episodic care. So these are the four that I thought about. And Kaylin, we have our second polling question coming up right here. So if you'll put that up.
Yes, our second polling question is, what is the one thing that really drives the practice crazy? One option is can't get the room temperature comfortable. Another one is the phone. A third is running around with like a chicken with their head cut off. The fourth is patients who don't pay their bills. And the fifth is scheduling is overwhelming. So we're picking up some votes right now. We're about 45% voted. In the lead right now is the phone is 50%, but we're only 50% voted. So let's give it a couple more seconds to see if we can get everyone to participate in this poll.
Yeah, we should have had multiple choices maybe. They're thinking about that now, or all of the above.
No, you do.
Yeah.
Oh, yeah, all of the above.
Yeah.
Maybe that's the problem. People don't know which one to choose.
Which is your biggest pain is then the question.
Yeah. We're about 70% voted. Can we get a couple more participants in this poll? All righty. Thank you. I'm going to go ahead and close this poll. I'm going to share those results. Dr. Sobel, we had about 8% that can't get their room temperature comfortable. 44% said the phone. 12% said that they were running around like chickens with their heads cut off. About 12% patients who don't pay their bills. And 24% the schedule is overwhelming to them.
Oh, they've tuned into the right presentation today then. Okay. So now the question becomes, another question coming up, but I'll have the answer for you. We always talk about medicine as being a business, so if medicine is a business, the question is, what are you selling? And the answer to that question, when that was posed to me a number of years ago, was I'm selling my knowledge. I'm a clinician, and patients are coming to me to partake of my knowledge. And I was flatly told I was wrong. The reality is patients can go to a lot of places to get knowledge. There's lots of smart doctors and nurse practitioners and PAs out there, so you're not selling knowledge. Okay, what your practice is actually selling is time. Okay, and if you think about it this way, that time is the only thing that's a variable, and that if time goes by and the appointment slot is not filled, the doctor or nurse or clinician, and I'll use those same terms interchangeably, are sitting in their duff in the back room waiting for something to happen, that time goes by and you can never sell it again. So time is what we're really looking at. So problems with your schedule, and you may want to check all of these, having to book appointments weeks ahead, so the patients can't get in unless they book weeks ahead. Your ill patients going to an urgent care center because they can't get in to see you when they're sick. Question becomes, do you offer same-day service? I mean, you can go to McDonald's at any time and get a hamburger. Do you offer the same kind of service to your patients who want to partake of your services? And importantly, is your schedule managing you, or are you managing your schedule? And if you don't know the answer to that question, then you have problems with your schedule. So going back to our 2004, here's the background. I sat and looked at this for a while, and I said, analysis of our appointment schedule shows there's a significant problem in our practice seeing ill patients in a timely manner. Patient dissatisfaction is up there with the wait to be seen when they're ill. And so if you're a front desk person, if you're answering the phone, you know this. You're getting, why can't I see the doctor? I feel terrible, da-da-da-da-da. You get that. Okay, there's significant clogging of the appointment schedule. There's no-shows indicating that there's a resolution of patient illness by other than seeing the physician. My definition of a no-show is a person who either got better, died, or went to the emergency room. But for whatever reason, they're not coming to see you, and so you're sitting with a blank appointment place on your schedule. Or if they all show up, you're seeing 2 and 3 patients in the same time slot. Ill patients have often become sicker while waiting for us to make them an appointment, and thus increasing morbidity. Luckily, there was no mortality, but we clearly had examples of patients of ours who became significantly sicker waiting to get an appointment. Next one is the key one, I think, for all of us, that it is unacceptable not to provide care which we ourselves would expect when we are ill. So if you're sick and you call the doctor, you want to be seen, and they put you off for 2 or 3 days or a week. I actually had one practice. I knew somebody who, for a sore throat and a fever, they said they could see the patient in 10 days. So all of these failures really leads to a failure in quality, and for our practice, it means that we were not reaching the mission of our practice to become the leading provider of health care in the state of Delaware. So I set this up in 2004. We called it Easy Access, like I said before. Our mission in our practice was to be the leading provider of family health services in Delaware. Our vision was to provide access for timely care of the ill patients by the physician or the nurse practitioner, and this will be done within 4 hours of the patient calling and asking for medical care. So that was our goal. All ill patients who call and say, I'd like to see the doctor, we will see them within 4 hours. Why did we pick 4 hours? A, we didn't want people driving crazy to get down to the office. B, the wait at the emergency room was 6 hours, so if we figured we could tell the patients they'd save 2 hours by seeing us, they'd come to us instead of the emergency room. So we had a meeting at our practice a little after 2001, and we discussed with the staff exactly what we were doing. And this is a key thing that the staff needs to know. We explained to them that during the past year we had had over 1,000 did not shows 1 and 2. So no shows. We just called them DNSs in our office. And this despite really trying to cut the number down by any number of means, all unsuccessfully, obviously. Patients complain that they have been unable to see the practitioner. So those of you who answer the phone, you know the heat you're taking from those patients, just upset that they can't come and see their clinician. As I mentioned before, we know patients were going to the emergency room, which we didn't think was appropriate for a lot of the conditions, and in one case, at least that we identified, a patient deteriorated to the point that they wound up being admitted to the hospital. When looking at the case, we could have probably treated them as an outpatient in the office and avoided a hospital admission. Fortunately, nobody died, which would have been a malpractice case where you just go down and sit in the big brown chair downtown at the courthouse and open up your wallet. The management appreciated there is frustration and stress among the employees attempting to provide care and for our ill patients in a system which was not able to meet the patient's need. And then again, just as before, that we felt it was morally and unethically acceptable to have a second standard of care for our patients that we ourselves would not accept. So how do we start doing all this? Okay, we've made this decision. First thing you need to do is assemble a team to address the needs that are going on. It is not adequate to have the physician make a declaration in the middle of the office saying that we're going to change things. You need to set an aim or a goal. So our goal was to see all patients within 4 hours. You then need to go ahead and make those changes so that the patients can be seen and you reach your goal. And then importantly, you need a measure to see, did things really improve, or are you just doing a little dance out there? There's any number of ways to measure how successful you are, both from the starting point and as you move on through changing to an easy access or open access appointment. I'm going to show you some numbers in a few minutes, and you'll see our numbers are very simple. Back when we did this, there really weren't this many metrics that you could actually choose from, so we kind of made up our own at that time. So how does the practice move in order to get to an open access thing? Well, first you need to measure the balance between supply and demand, and we're going to talk about that. You're going to need to reduce the patient backlog. So if you're sitting there and double and triple booking, how do I now go ahead and make space for sick people to come in on the same day? How do I reduce my visit types, which you'll see is a hindrance to getting to an open access? And what plans do I need to make for the flow, either up or down, in the practice so that this works consistently? And lastly, how do I reduce the bottleneck that's occurring on the phones in the front office with my staff? So we need to look at drivers of capacity. First one is the clinicians. How many clinicians do you have? Do you have enough clinicians to see all the patients that are in your practice? If you're short, then this is going to be difficult to do. You need to look at your start and end times. Okay, what time does your practice open in the morning? Is that an accommodation for your patients? What about in the evening, patients who need to get in after work? And again, how many sessions do you have? Do you see patients every day? You only see them 3 days a week? You need to think about all of these things. What are the purposes of your visits? Okay, how many different visit kinds do you have? And I'm going to show you that in a minute. How long are your visits? Are you allowing adequate time for patients to be seen? And how complex are your patients? Some of you out there may have extremely complex patients. Others may be a simpler solution. So here's the schedule. It's not ours. But I wanted to show this to you, and I think this is all hypothetical, so we don't have to worry about HIPAA laws. But take a look at this. Up here in the beginning, Dr. Butler has a double here. It's in yellow. I'm not sure what the yellow means. I don't have the color codes for this. There's another double down here at the bottom. That's dark green. Over here, Dr. Thomas has a light green one, another dark green one over here. Here's a pink one over here, and a dark blue over here. So there are double appointments that are in different colors, which I suspect means that they are available for different purposes. And you have to ask yourself the question, why do I have to have different colors or different appointment types for those appointments that are doubled? And the same goes for, in this case, quadruples. So here's a red one, here's a blue one. What's the difference between this and this that we can separate and out there? if you're a receptionist and you have to learn the color system, you go nuts. I mean, we used to have a system like this, and I could never understand, and I thanked my receptionist every day that they could actually figure this out. But really, do you need all this variability in here? If a double is a double, why can't you see any patient that fits the double criteria in that slot? So, if we're going to go to an open access, how many patients are going to be calling you every day in order to be seen because they're ill? And in primary care, there is actually a number for this. Specialty care, I've not seen numbers, but it's easy enough to figure out. It's all you have to do is have some secretary, one of your secretaries, keep account of all the patients that call up and then say, oh, I'm ill, I need to see the doctor today, or the number of referral doctors who call up and say, I have a patient that you need to see, and just that gives you the number. And if you count for a few days, you'll get the number real quick. But here for primary care, when we did this, if your panel size, so the number of active patients you have in your practice is 10,000, you're going to be needing 50 slots a day. So you're going to get 50 calls a day for patients who are ill. And it's almost a guaranteed number that's out there. So 10,000 active patients, you're looking, depending on how your practice is set up, 4 or 5 practitioners. So really, if you say, 5 practitioners, each doctor, clinician has 2,000 patients, you're looking at basically 10 open slots per clinician per day. Do you need to make a variation in the schedule? How firm is that number? And the number is that's not 100% firm. You need to figure on Fridays and Mondays. It's going to be a little nutsier, basically, because you're either coming off a weekend when patients are sick, and so they're calling up Monday morning going, I've been sick all weekend, I got to see the doctor, or they're calling on Fridays because tomorrow's Saturday and they need to go out Christmas shopping, and they want to see you to get better for this. You need to make allowance for things like holidays, vacation. So if one of the clinicians is off, you still need the same 50 slots in the example that we're using, so that means others need to pick up more open slots. Staff illness, seasonal issues, flu season, obviously in a primary care, increases the demand, and you kind of learn to deal with this. And then, of course, when your staff may be off at meetings or other things. So the 50 is not a hard number, but it's a pretty good number. And consistently you need to have that every day. So if you have a time, if you have 5 clinicians and 3 of them are on vacation, the other 2 are going to be seeing mostly open access because they're going to need to have 50 slots built in. How do we switch over to open access? We're going crazy in our office. There's some chickens with their head cut off. The schedule is killing them, as I recall. You need to work down the schedule. And you can do that in a couple different ways. You can work overtime. I've seen practices where they just, instead of closing at 5, work till 8 o'clock at night. Doesn't do great for the finances, but it gets it thinned down. You can use the quiet months. In a lot of practices, the month or so before Christmas gets to be real quiet. Nobody wants to come in and see the doctor before Christmas. And so in that overtime or that quiet time before the holidays might be a good time. Another way to do it is to defer the routine follow-up visit. So if typically you see, let's say, a type 2 diabetic patient for routine follow-up every 6 months, temporarily move it to every 8 months, so you're stretching the patients out a little bit. If you're looking at your schedule and you've got 10,000 patients in your panel, but you've only got 2 clinicians, then obviously you need additional practitioners or some way that you really are distributing the load better. So what are the fears of practitioners in doing all this? Okay, that they're going to be overwhelmed by the demand of sick patients who want to be seen. And the answer is, if you've done the math right and everything works, you will not be overwhelmed. The numbers actually smooth out, and I want to show you that in a few minutes. That you're going to be sitting with open slots. Doesn't happen. Really, you get closer to 100% booking, not the 120% booking that you're doing. Occasionally patients won't show up. That, you can't take away no-shows for sure, but the open slots pretty much disappear, and you can actually use those open slots for other things. Patients complain, I can't see my doctor. They call up for a sick visit. Well, sometimes that happens. If I have 10 slots, I may fill up all of my 10 slots quickly during the day, but one of my associates may have some open slots because that's the 50 that we're going to have per day. And I think as a receptionist, it's easy enough to tell the patients, well, you could go to the emergency room, but on the other hand, instead of seeing Dr. Sobel, you can see Dr. Smith, and Dr. Smith will have your records, know all about you, and really be able to understand what's going on with you. And worst comes to worst, he can stick his head in Dr. Sobel's door and get an idea if he needs to do that. So they can see another physician, but it works out. Or they could wait to see the doctor. Okay, and we'll talk about that a little bit. So the challenges that practices worry about is what happens if the phone doesn't ring. I can guarantee you it always rings. The appointment backlog we've talked about a little bit. We need to get rid of that. We need to work on panel size, either more practitioners or decreasing the panel size, whatever works in your location. And then the overflow issues that we've talked about, but those will all disappear if we follow the sequence. And then, of course, provider absence. We always have to make allowance because those same patients are going to be calling, those 50 a day are going to be calling to be seen. So we talked about appointment types. The first thing to do is reduce the number of appointment types so that we cover more issues per visit. So that a patient who comes in, let's say we have single appointments, we'll make them 20 minutes apart. So a 25-year-old comes in with a sore throat and a cough. Really, it's going to take the clinician probably less than 10 minutes to see the patient. So now there's 10 minutes left over. The next patient who comes in with a sore throat and a cough is a type 2 diabetic, and when you look at the chart, the patient hasn't been in for 9 or 10 months, and now you've got the patient in front of you with a sore throat and a cough, but you can also take their shoes off, start to check their sensation, do the diabetic stuff, issue a lab order, and renew medication. So you're in effect max packing the visit. So now that diabetic patient doesn't have to return again to be seen again now for 6 months because you're really taking care of multiple needs of the patient. Sounds crazy, it works. And by reducing the appointment types so that you really maximize the use of your clinician time and space, you get the response of, oh, you mean I can come in right now? And when patients say that to you, I mean, they're literally shocked when you say to them, if you're running a double or triple book thing, that you mean I can come in right now? And the answer is yes. Really works out pretty neatly. Let's stop for a second. Kaylin, we have our next polling question here, so we can direct our way forward.
Absolutely. So the next polling question is, the schedule we are currently using is 1, chaotic, 2, traditional, 3, open access, 4, carve out, and 5, advanced access. Give it a minute to pick up some.
And you may not be sure what kind you have, and we're going to talk about that, but if you can't define the type of schedule you have, it may say something.
We're about at 44% voted, 50% voted right now. Let's see if we can get up to the 80s or 90% voted before we close this poll. Climbing. Give it another 5 seconds. All right, I'm going to go ahead and close the poll as now, and I'll go ahead and share those results with you guys. Dr. Sobel, we had about 4% said chaotic, 74% said traditional, 22% said open access, and we didn't have anyone respond in regards to carve out or advanced access.
Okay, very good. Okay, so there are various scheduling models. There's the traditional, which we know as double booking or overbooking, so fill every appointment every day, keep me booked, and even if I'm booked 3 weeks ahead, that's fine. That one really attempts to get rid of no-shows, but actually makes it worse, as we'll see. Carve out, we reserve appointments for the same day, so sort of like an open access. Now, in true open access, they're all same-day appointments. That's a little nervy. I'm not sure that I can live with that. Patients call back later for needs. And then there's advanced access, and you'll see practices that work that where there are no appointments, and whoever calls you see that day. And that's going back to McDonald's. That's the McDonald's method of practice, and so you're okay unless the bus arrives with 200 members of the local college band who are all now coming in to get their cheeseburger and fries, and you're completely swamped and going home at 9 or 10 o'clock at night. So let's talk about the did not shows, and I made this graph up back in 2004, or actually a little before that, looking at who are the no-shows. It's a little confusing, so let me walk you through it here. On March 22nd, so this is what we call our index day, we had the following patients. A follow-up visit was a no-show, a physical exam, a URI that was made the day before. I don't remember what NPAP is too many years ago. Somebody with shoulder pain who had called in on the 19th, another follow-up patient who called in on the 19th for a follow-up visit, and 3 days later is not there. But look at this one over here. Look at March 20th. On March 20th, we had a patient with stomach pain, a sick patient, and a patient with a swollen finger, all of whom were no-shows, same day no-shows. Now, unfortunately, I don't have the schedule, but as I recall it, these were appointments that were made, first thing in the morning, and we told the patients they could come in, in the late afternoon or the evening to be seen, and in between, as we talked about before, they decided that they'd rather go to the emergency room or some other way deal with it. But in addition to these three, we had the day before somebody who called to be seen for arm pain, somebody whose allergies were flaring, a patient with knee pain, patient for blood pressure, an ear infection, okay, and a patient with some kind of finger problem. So on the 20th, we were looking at 3, 5, whoops, I'm sorry. Let me take this back here. 3, 5, about 9 patients, doesn't want to stay back there, who are no-shows. And those are time. That's time that's lost. Patients that don't show up and within your practice are not seen, and your doctor or clinician is sitting around waiting for something to happen. Or in the event that they actually had all shown up and double booked, you're going crazy. So and open access deals with no-shows. It helps to reduce the rate. We're going to see that in a minute. The literature says 4% is an acceptable level. Ideally, you'd like to obviously get to 0. If airplanes crashed at a rate of 4% of all flights, that would be a national catastrophe, but we're not quite in that serious level. It helps with overbooking by having open access. You have to ask yourself why your patients are no-shows. And when we looked at it, it was A, long out appointments, so patients who made an appointment days or weeks ahead of time. Young males, interestingly enough, we found out young males are typically no-shows. So this is your 20, 30-ish year-old males. And Medicaid patients, and the reason that most of them did not make their appointments was they couldn't get a ride. So they made the appointment and then started scrambling to get the ride. We reversed that with open access, saying, you get the ride, call us, and we will see you today. We tried automated reminders. It works somewhat. Written reminders for patients that are further out. We used to tell patients that a no-show deprived another patient of being seen because we weren't going to double book or triple book. The reality is patients could care less about other patients, and so they are only concerned about their own appointment. We could also talk about charging for no-shows. We tried that. Honestly, most patients won't pay for that charge when they see it come up on their bill. And for patients, for instance, with Medicaid, you can't charge them, and there's really no impact to it for those patients because there's no, as they say, skin in the game. So we set up some rules for easy access within our practice. We're back again in 2002, 2003. And the first rule is that easy access guarantees that the sick or ill patients will be seen only on the day that they call. So that if a patient calls up today and says, oh, I have a sore throat and a fever, I want to come in tomorrow on Friday, the answer is no. The answer is, we will see you today. Can you get down here, at one of our open access appointments, and give them a time? And if they say no, I want to come in tomorrow, then we tell them to call back Friday and make that appointment. And we guarantee them on the phone that when they call on Friday morning for that same sore throat and fever, that we will see them on that day. 100% guarantee. So the goal is to have the patient who wants to be seen urgently, seen by the practitioner, not more than 4 hours after their call to the office. Only appointments such as physicals, pap tests, things where patients may need to get laboratory work or other studies done can be booked beyond the current date. Patients who call to be seen for an illness or injury, again, will be booked only on that day. So that was the rules we set up for the staff. And I made up this nice little graph or chart so that the staff could understand and make sure that we followed the rules. So over on the left column, what is not an easy access appointment. In the middle, what may be an easy access appointment. And on the right side, only easy access appointments, so illness and injury. And so that was the rules that we gave to the patient, to the staff to work with. It was a catastrophe. Didn't work at all. The staff really couldn't get it. When we had new people come in, they couldn't get it, so that it didn't work at all. So I went back and rewrote it and redid it again, and this is our new or revised guide for our staff, and it's 3 columns. I've got 2 on this slide and 1 on the next. And so again, over on the left side, what is not an easy access appointment, and so we defined that very clearly, what could be booked in advance. Things that might be an easy access appointment that are in there, and we spent some time considering that. And we even allowed some of the slots for what would be considered routine stuff to be seen in easy access, and it worked pretty well. Staff actually got to know pretty well how to balance that, but the third column was really the one that we wanted to guarantee, because what we had heard from the patients was, I told them I was sick, but I couldn't be seen. And so we actually made up a list. I made up a list of some of the symptoms that commonly the patients would present with that would be same day. So my foot is swollen, my back is hurting, I'm dizzy, I don't feel well, I have pain. And so we clearly defined for the staff what worked, and they got it. They got it. They understood how it worked. They would come and ask, well, does such and such fit into this listing? And we either tell them yes or no. But it really clearly identified for the staff. So when we talked about before, you need to go back and see how things work. So how well did all this work once we got this grinding? A little bit confusing graph, but let me take you through it. We put in easy access somewhere in 2001. So I went back to 2000 and said, okay, during that period of time, we had a month of April of 2000, we had 1,882 visits. With our move to open access, we increased that to 2,000, so there was, approximately 200 appointments gained. And April of 2002, we were now up to 2,300 patients visits. So we're looking at what, close to 500 more visits per month in here. April of 03, the numbers went down here, and when we looked at, we figured out one of the docs was actually on vacation for a couple of weeks, and we lost out on that. But basically, the numbers all began to increase over time. Now, some of the factors we can't control, like hospital visits, there were only 20 in 2000. They went up to 157. You can't control necessarily who's in the hospital. In our practice at the time, we were doing physical therapy. And so because we were seeing injured patients more frequently and we could get them to physical therapy when appropriate, we went from 266 visits to 429. Immunizations you would expect to stay fairly constant. I mean, if you're seeing same workload of kids, that stays pretty constant over time. Miscellaneous was all the other stuff. So basically we moved our total number of visits from 3,000 back in 2000 up to, let's say, 3,900 here, because remember, this month's a little wacky. So a pretty significant 900 visit types more over time, and with the schedule really unchanged. So same number of docs, same of everything. Look at this bottom number over here. Here's our missed appointments. Here's the no-show appointments. We went from 107 here in April of 2000. Dropped down, went up, but then really when we put pressure on it, dropped down to 39. So huge drop. There's another column that comes under here, which didn't get onto this slide, is the finances, is the money, and I can assure you that that went up substantially. We repeated it again in May, and the results actually are pretty much the same. So we've showed some pretty much consistency. Again, here we showed DNS is dropping from 106 down to 70. So this is 36 visits that opened up. So this was 36 slots that we could use elsewhere in there. Did we get to the 4%? I don't know. I didn't do the math, but we're getting there. So really, when we look at open access, it's better patient care. We're seeing sick patients in a more timely manner. Definitely improves patient satisfaction. Once the patients got over the idea and got used to the idea of an open access, they loved it because they knew they were sick. They could see their doctor. Their records would be there. They didn't want to spend hours in the emergency room. Our staff satisfaction, you don't have to have fights with the patient on the phone or at the front desk when they walk in demanding to be seen. We think our higher preventive medicine rates went up because we were catching the patients like the diabetic who came in for a sore throat but hadn't been seen. We think we were higher monitoring of guideline compliance, so we were practicing better medicine overall, and we reduced our malpractice risk, okay? So the patient who got sick and wound up being admitted to the hospital, like I said before, had the patient died, that would have been a catastrophe for any number of reasons. So we think we reduced our risk because we were seeing patients promptly and really being aggressive at treating them. There's a number of tools that you can look at for what works. This book by Susan Houck, I think, is still out there and is available. There's additional resources. IHI, the Institute for Healthcare Improvements, has a lot of information on open access or primary care access or whatever you want to call it, but you can do a lot of searching. A lot of the professional journals have had articles over time on how you can put an open access process in place in your office. And that's it. And Kaylin, I'm back to you.
Sorry, I was on mute. At this time, we have about 12 minutes left. If anyone has any questions or open discussion, you can go ahead and either type out questions in the question bar, or you can raise your hand and I can unmute your line so you can speak directly to Dr. Sobel. All right, I have Cindy. I'm going to go ahead and unmute your line. Cindy, are you there?
Hi, Dr. Sobel. I am. I'm here. Hi. Could you talk a little bit about how you guys educated your patients on making this change and why you made it and how it would work for them?
Well, we actually had a handout that we gave to patients initially, but I'll tell you, it was, I have to admit, it was painful. Because you'd actually get into a fight with the patient when you said, I won't make an appointment for you, or I wouldn't say, but our staff person would say, I won't make an appointment for you for tomorrow with your sore throat, but if you call back tomorrow, we'll see you. And they didn't believe that. They thought that was just insane. And so they would get into kind of fist fights with the patients over the phone about that. But when they actually got the appointment and we guaranteed it, and our guarantee was a guarantee, it worked out. I would say it took us 6 or 8 months to settle it in fully with all the patients, and at this point the patients know that they can call up. Now if you call up at 7:45, you're not going to be seen at 8 o'clock. We decided that having patients die on the streets racing to our office to get there in 15 minutes was not going to work. but we will see you before noon. So if you call up in the morning, we'll see you before noon. So we set up a block of appointments at around, I think 10:30, 11 o'clock in the morning, and that's when our open access was. You don't want your open access when you first open the doors because nobody can be there. And then we had another little block later in the afternoon, and then a final block. We have evening office hours, and then a final block just before we closed. And actually doing it that way, just in case you didn't fill. I mean, sometimes it gets quiet. You get the nice weather, nobody's sick, there's no sore throats. Then it allowed the docs extra time to catch up, do their paperwork, and do other stuff, but at least you weren't missing stuff. But it's rare that you had open appointments.
So there was a little pain at the beginning to get it implemented, but now you've been doing this for a while. How has that affected your patient satisfaction with the practice?
Oh, yeah, I think there's no question of it. I mean, patients call up and they want to be seen, and you used to get I've been coming to this practice since 1953, and you mean you can't get me in to be seen today? I feel rotten. I mean, you get that stuff, and if you're a receptionist, you're on the phone, you're really, putting up the shield for the doc, and you're taking the heat because I can almost guarantee you that when the patient gets into the room with me, they are not going to say one word, good or bad or indifferent. Well, they won't say a bad word like your staff wouldn't let me get in to be seen. They just dump it on the staff. But now with an open access, it was amazing how often the patients say to me, "This is terrific. I can't believe I got in to be seen." My friend goes to another practice, and she can wait days to be seen for her illness. So it really, huge satisfaction. Huge satisfaction.
Great. Thank you.
Thank you.
Yep.
Great question. Anyone else? Alrighty. Well, we have about 8 more minutes left of the allotted time, but I can give that back to everyone, of course. A copy of this webinar will be emailed as a follow-up, and once the webinar has ended, there will be a short survey that we ask everyone to participate in to kind of give a little bit of feedback on today's presentation and how we can progress moving forward. So thank you, Dr. Sobel, for your time today, and thank you all who were able to attend.